My name's Dr. Sharon Abrahams, and I'm a consultant clinical neuropsychologist and also a senior lecturer at the University of Edinburgh. I've been here since 2004. I actually started my work in ALS, or motor neuron disease, with Nigel Lee's group down in London, which was about 20 years ago, so quite a long time ago now. And I worked there for over 10 years and then moved up to Edinburgh. Here at Edinburgh, we've set up 2 centres which are related really to ALS, the primary one being the Ewan MacDonald Centre for MND Research, and we're also now recently set up the Anne Rowling Regenerative Neurology Clinic.
So you have worked with people with ALS for many, many years.
Yes, I have indeed. It's a strange area in terms of once you're in the area with ALS, it's something that you become a lot of researchers come very committed to. Because you can see that there is lots of progress being made, but there's also lots of room for progress. So it's an area I think that a researcher can make a big difference to. So that's what's kept me going.
And at the same time, helping people with the disease now to face these challenges.
That's what's happening now. I think it's a very exciting time now because some of our research findings in particular are now coming down to the clinic. So I've spent all these years interviewing people with ALS and their husbands and wives to find out more about the disease. And now some of the research is actually feeding back into the clinic. So again, it's a very exciting time for us.
So I think there you're getting at the idea of ALS being on the same clinical spectrum as FTD, the discovery of C9 and such. But before we get there, I thought we could begin by saying, okay, we've known for quite some time that people with ALS have cognitive challenges. Why do you think it's taken us so long to get here, to accept this part of the disease?
There are, I think, quite a few reasons. Some, I think, are specific to ALS. With people with ALS, we know that they present with very rapid and severe and disabling physical disability, and people, suffer with that, and ultimately they will die from disorders related to the motor dysfunction. And the research as such has very much focused on the motor system. It's been very much neurology-led, not led by psychiatry or psychology, and very much focused on the primary symptoms that people show. And that's fine. And I think it's been a little bit of a perpetuating cycle because it was actually seen, I think, as a saving grace by many patients and clinicians that although my body is deteriorating, my mind is not affected. And so I believe that this was a little bit of a self-perpetuating cycle. But in fact, these kinds of physical problems, I think, can mask the cognitive problems. So for example, if people do develop problems with their speech and then therefore have problems with communication, it may mask in some people an underlying problem with their language, for example with their spelling or the construction of words or sentences. Also, in terms of more subtle changes that we get in cognition, when a person is diagnosed with ALS, once it becomes physically disabling, they stop working. They also become very reliant on other people for their daily needs. So they're more reliant on other people to help them organize their day, in terms of getting dressed, in terms of doing things. And so there are really less demands placed on effective, high order thinking. You don't have to do so much. It's not as if when you're working, when you really have to perform on your own all the time. So you're much more dependent on other people because of the physical disabilities. And I think that also keeps some of these cognitive problems hidden from view, in terms of it doesn't have too much of an impact until something happens. So, for example, people have something novel comes into their life. For example, they have to cope with a communication aid, or they have to cope with a new piece of ventilation equipment. And then we get maybe problems. Someone realizes, oh, they're not picking this up as quickly as they should be. I'm quite surprised. So I think that the physical problems can mask certain cognitive problems. Another issue in relation to the type of change that you see with ALS is that people may have changes in their behaviour, and this is related to the frontotemporal dementia symptoms. And these are changes which may be slightly disinhibited behaviour, maybe slightly inappropriate, or maybe they're not showing the empathy that they used to show with their partners, etc. And I think these behaviour changes might actually be misattributed. So on occasion, because you expect someone to be reacting badly because they've had a diagnosis of a terminal illness. So we will expect some reaction from that. Or that you might think, oh, they're behaving that way because they're really suffering with the physical problems. Or you might even misattribute it to a breakdown in marital relation, that they're just not getting on with their partner anymore. And in fact, I think that's also covering some of these behaviour changes that I think are actually an integral part of the disease. Now, with that in mind, with that, the idea that, obviously we know it's very physical disability, and we've focused on that, and these physical disabilities may mask the problems. If we actually look back in research in terms of the history, there were some early publications. There were publications as far back as it's the early part of the 20th century. So 1932, there was a publication which related ALS to Pick's disease. So, which we now know is, or more commonly, frontotemporal dementia. Now, that's a long time ago already. Now, these publications weren't in English. They were in the European literature, for example, in German. And so the English-speaking neurologists didn't really pick up on this train, probably until, I think it was probably Arthur Hudson's work in 1981, and who published those series of cases of 30 people with ALS plus dementia. Now, at that time, dementia was also really synonymous to what we know is Alzheimer's disease. And that's not the type of dementia we see in ALS. We see a very different type. We see this frontotemporal dementia, and it presents completely differently. So with Alzheimer's disease, people have these memory changes. In the FTD, the frontotemporal dementia, it's more behavior change, personality change. And so really, it was only in the early 1990s, that we had this huge progress in diagnosing frontotemporal dementia in the general population. So frontotemporal dementia, which occurs without ALS. And there was a big push in diagnosing that, and new diagnostic criteria came up. And it's since that point, we've now seen, hold on, we can see this now in ALS. So if we apply those new diagnostic criteria, underneath the mask of the physical problems, we're picking it up. And so, it's since the early 90s, and since I've been working in this field, which is then that we've had the push in terms of detecting this, the cognitive or these behavior problems. It's also been now, again from the early 90s, supported by imaging findings. And that also made it more established that this is a real and true part of the disease. And so it started with actually some very good functional imaging work by the German group and the British group, and then also now more structural imaging and more advanced imaging. So I think it has been there, but because of the such severe physical problems and people really progressing so rapidly, I think we've tended to misinterpret it or certainly misattribute these changes. And maybe that's why it's taken a little bit longer for us to pick up on them.
Absolutely. So now with the discovery of ALS being on the spectrum, it's almost like everything is now starting to make sense.
Yeah.
Pieces of the puzzle are coming into place. Oh, that is why we're starting to see this or that behavior in that person, in my patient. And it's that sort of conversation that's now happening, as you said, with people who are looking at the brain at the same time as people who are working with patients, as well as people like yourself that are managing this cognitive issues. So it's this combination of now, okay, we have to do something about it, and it's sort of following the trend of multidisciplinary care for people with ALS.
That's right. So when we talk about this spectrum of change, because people talk about it, and I don't think they quite, understand what it's a strange term, really. So it's what we're talking about in ALS is maybe just a small subgroup of people who have this associated frontotemporal dementia. And the link with frontotemporal dementia is now really established, not only in terms of the types of behavior and changes in thinking, but on a pathological level and on a genetics level now, because we have now linked genes. And so it's maybe only about up to about 15% of patients we'll see in our general ALS clinics would be categorized as having a more full-blown frontotemporal dementia. But then we have this, so that's the extreme end. The other extreme end is the other half of people who have just motor symptoms. And in those people, it does really look like a motor neuron disease. I don't see changes. I do think there are these, I would say up to about half of the people that we see in the clinic will not have these changes. Then you have this middle proportion of patients, which may be around 30% of people, who have more specific cognitive problems, but they're not severe enough to be diagnosed as a frontotemporal dementia. So when you assess people with more a cognitive screen or a cognitive assessment, you'll find problems in things, what we call executive functions. So that's more higher order thinking. So it's things like planning, organizing, paying attention to things, or monitoring what you're doing, maybe changing your behavior because you've done something wrong. So those more higher order functions we find in some people. In others, we find a little bit of language problems emerging now. And some people, we also find this problem in what's emerging now in social cognition. So that's the ability, it's the cognitive ability to interact with other people appropriately. So, for example, if I'm talking to you, I will imagine from your perspective how things are sounding and how things are your view of the world. And so it's that ability that we think is also impaired in some people with ALS. So it's emerging that this cognitive and behavior symptoms are really an integral part of the disease in a quite large number of people with ALS, but not everybody. And so that's why when we talk about spectrum, we're just talking about the degree of severity of these changes, or if they're present at all.
So studies from Massimo Filippi's group in Milan suggest that certain compensation could happen in the brain. Certain things in the brain may change or whatever to help mitigate these cognitive challenges in some people. But I think also, according to your studies, many more may be actually subclinical. So yeah. I'm hoping that you could sort of talk a little bit about that.
Yeah. So when I talked about some patients having this subclinical dementia syndrome, I'm talking about that around that 30% of patients. So they have these very specific changes, such as this changes in problem solving or decision making. But as I say, it's not so severe that it would be diagnosed as a frontotemporal dementia. And it may be impacting on daily life, but maybe not as much. And as I say, the physical problems may be masking most of that. In terms of, so I do think they do show a pattern of change, but it's just not of a level to be diagnosed as a full-blown dementia syndrome. And in terms of Massimo's work, it's very interesting work, and this is basically from the functional imaging work. And what's been shown is that functional imaging has really supported, and structural imaging has now very much gone on to support these changes outside of the motor system in other areas of the brain, particularly the prefrontal cortex, particularly the frontal lobes. And in terms of Massimo's work, when we see some changes in functional activity in one part of the brain, maybe it's not functioning as well, there is a suggestion that other parts of the brain increase their functioning to try and compensate for doing a particular task. And I think that's probably true. I think that's probably true of all types of brain injury. When we have an injury to a particular part of the brain, other parts, or we certainly have more wider recruitment of brain areas and pathways to perform the same task. Now, if someone has maybe a subtle, more specific problem, it may help to alleviate their function on a day-to-day activity. So maybe they're getting around it by, using other strategies. The problem, though, really occurs when it doesn't. It's not sufficient to alleviate function, and which will happen. I mean, we're picking up on screening, so I think it is happening, particularly probably as the disease progresses. We even see that phenomenon with the motor system. It's not just with cognition. So we see it when on functional studies which have looked at, for example, joystick movements, just moving a joystick with your hands. Now, if that limb is affected, we will see on the brain image that other areas are recruited more to try and help that movement and alleviate it. So it is a phenomenon that I think occurs across brain injury, and very interesting for us in terms of, to investigate with ALS.
Absolutely, because it seems to me that if we can get a sense of how certain people are compensating, maybe we can learn a little bit better about how to maybe manage not only their disease, but also other people's diseases as well.
Absolutely. In terms of rehabilitation, the compensatory strategies are really the prime pathway for actually getting people to have some kind of rehabilitation program. So, looking at those compensatory strategies are really, I think, it's the next step now in terms of cognition. And that's something certainly that we'll be doing in the future.
So thinking about right now in the clinic,
yes,
what tools do we have to be able to pick up on these changes in people with ALS?
Okay, so there are a number of tools out there at the moment. So, for example, that people are using. So, for example, there's the frontal assessment battery, but it hasn't been designed for ALS patients. And there's a problem with this, in that with ALS, with such a range of different types of physical disability, it may affect people's writing, their drawing, their speaking. So it means that only some parts of a test may be performed and others not. So tests that are not specifically designed for ALS, I don't think are of limited use. There was one nice measure produced by the San Franciscan group, which is the ALS Cognitive Behavior Scale. But that test is a very brief test, but it only assesses these executive functions. It's not, we would say it's a single domain test. So it doesn't, it's not sensitive to the range of problems that we get in ALS. So we also get changes in language function, and that's not assessed by that. Now, we have just now launched our own test, which we have in press at the moment in the ALS FTD journal, and that's called the Edinburgh Cognitive and Behavioural Screen, and that's multi-domain. So it involves it's a very quick screen, so it's between about 15 to 20 minutes, designed for a nurse specialist to run in a clinic. And but it's multi-domain, so it assesses some functions which we think are specific to ALS, which are sensitive to ALS. So there's an executive function, so these higher order problems, language, social cognition, but it also assesses some functions which we think maybe shouldn't be impaired in ALS. For example, some visuospatial functions. Now, one of the reasons we've included that is because we'd like to be able to differentiate when people have cognitive problems which we think are due to the ALS, or maybe they have cognitive problems due to something else. Maybe, a lot of people are in the older adult population. They may be developing, for example, mild cognitive impairment leading to Alzheimer's disease. So we want to be able to differentiate those types of cognitive problem. So hence we made our own screen, which we're now just about to present at the end of next week at the European ALS meeting, ECAS, and also at the ALS FTD meeting in London, Ontario, in Canada next week as well. So I'm hoping that will really push forward in terms of identifying who in the clinic has a cognitive problem.
Absolutely. And so, I think a lot of us are really, hearing this. We're thinking we've heard about a lot of different tests now. We've heard about the ALS FTDQ, I think.
Yes.
There is some talk about from ALS-MND last year about ALS Plus from a group in Australia. So what I'm hearing is, I think that what you're designing is the first pass, the idea being when they first get into the clinic and you're trying to get a sense of this patient and what the needs of this patient may be, this is an all-around test to get a sense of what, if any, cognitive challenge there may be. It'll help us get a sense of what they may need in future years. Whereas
exactly.
Right?
That's right. And it is a screen, but because it's multi-domain, it's got lots of different aspects to it. We hope that it will, firstly, we want to identify who has the impairment, what type of impairment it is. So if someone just has some problems with their language, we want to know so that we can then implement strategies just for their language. And then how severe is that impairment? So if someone has an FTD, frontotemporal dementia, we want to know that. The next step after that is really, once these people have been identified, the level of impairment is really several-fold. Firstly, it's about education. So we can educate the person with ALS, their husbands, wives, any clinicians as well as involved on their specific profile. So what's wrong? Well, this person we think has some problems with that may affect their decision making. So therefore, the clinician in charge will say, okay, well, we want to intervene with this particular program. Let's say it's a ventilation program. We need to discuss, take more care in getting them to make decisions over that treatment. And so by using this screen, we hope that it will tailor intervention more so to the individual from a simple screen. The other thing in terms of so I do think this is the first step for really going into managing these cognitive changes. So we're really just, I think, at the moment, just about to break through on that level.
Absolutely, and at the same time, I think based in I think it was Zach Simmons' words, do something about this alphabet soup of various different strategies that are out there.
Yeah, I know. It's true. We're trying to, it's very difficult. I mean, we're happy with this measure. So I'm hoping, at the moment, we're running a large validation study of it. As I said, the paper has just come out. But we're running a large validation study and have it translated into a number of different languages already in Europe. So I'm hoping we'll get more centres in Europe adopting it so that we can compare data and see exactly what's going on. Ideally, this is we just want a measure that's easy to use in the clinic, and people will be able to also see what happens on the first assessment, and we try and do it very soon after the first initial contact with people, and then see how, if things develop, as I say, I think maybe some cognitive problems will emerge possibly in some people as the disease progresses. And again, so it's about monitoring that and implementing strategy when we need to.
Absolutely, and it's really exciting to hear that you are working with so many people across Europe, because it sounds to me like the real key here is to get it in a lot of places with a lot of people with ALS, so we can get a sense of how well it's working, tweak it so that we can get it, standardized, validated, and into the clinic as quickly as possible.
That's exactly what we're doing now. So we've just published just the test now with some initial data, and the validation study is underway with our collaborators. So at the moment we have collaborators in Ireland, Switzerland, Holland, and Italy performing the tests. So it's getting there. So
that's really exciting. Yeah. So I think another thing that has occurred to me as we're talking about it is, I think a few weeks ago, maybe a few months ago, Orla Hardman's group recently published this idea that people with ALS experience cognitive challenges progress more quickly, people who typically participate in clinical trials. So as we're sitting and we're talking here about a time where we may not quite have these tools, at the same time as we may not know how to best manage these patients, what challenges do you see or anticipate in clinical trials?
Well, in my view, screening should be done for all clinical trials. I'm quite surprised it hasn't been done yet. I mean, it's to me, if you're having up to 50% of people with some form of cognitive problem, which implicates that other areas of the brain are affected other than the motor system, you need to assess this as people go into trials, because we need to assess the effect of whatever drug it is on these symptoms, not only their motor dysfunction. So it's about, and you also need to know whether your drug is working on specific groups of people and not others, so we don't know. So it's about monitoring people, phenotyping them. So, this person has, frontotemporal dementia, this person has nothing, it's just the motor system, this person has maybe a more subclinical problem. So looking at the range, the heterogeneity that we get, and then monitoring them through the particular drug trial. So I think actually it's pretty essential. We don't know yet what the causes are. I mean, we don't know the causes of the motor degeneration. We certainly don't know the causes of the cognitive degeneration and whether they're the same factors. So we need to monitor it. So we need to know what's going on. So I think it's essential now that we are getting these tools to incorporate them now into trials and see what happens.
And it seems to me that based on what you're saying, that it would help us get a better sense when we're developing these medicines, what in terms of subgroup analysis, what medicines would be best for them as well. Give us more information, not only to deal with the heterogeneity problem.
Exactly. I mean, some of the drugs that have been trialed have a behavioural effect, so it would be interesting to know, particularly, has this had any effect on maybe if people were showing some mild behavioural changes, for example, if someone's slightly disinhibited or whatever. I mean, at the moment, because they haven't been incorporated in trials, we don't know if there was any effect. So that's right. I mean, the key is that, these changes are part of the disease, and, addressing one aspect of the disease without the other seems a little foolish at this stage now that we have this knowledge. It is more about trying to address the whole, all aspects of the disease.
But it seems to me also, when you look at clinical trials and who can enroll in them, there are some trials that are excluding patients with certain cognitive challenges. So it seems to me that putting these tools in place may not only help all clinicians develop better treatments for the disease, it may also allow more patients with these challenges to participate and get access to these medicines a little bit earlier.
I think that's right. I mean, exactly. I think if you know what you're dealing with, then we can see what happens when you take the drug. But you have to have some measure or some description at the onset, at the start of the trial. Excluding patients is, I don't see that as a way forward in particular as well. As I say, it's so many people have some type of cognitive change. We have now genetics that are pulling together these groups, that you'll be excluding a lot of people if you just excluded patients with some kind of cognitive problem. So I think it's, at the moment, it's more, an inclusive approach, but monitoring what happens would be, I think, ideal in this situation.
So these tools are going to be particularly invaluable. And so we really look forward to hearing more about what happens.
Absolutely. So do I. So that's what we're aiming at anyway. So.
I want to thank you for joining us today, Sharon, and talking to us about such a difficult topic for so many people.
Oh, you're absolutely welcome. Thanks very much for inviting me.